Hello everyone. Today I'll be discussing early childhood caries. Okay, it's a very vast topic and I'll be quickly explaining about all the aspects of ECC. So by definition, which is given by American Academy of Pediatric Dentistry, ECC or early childhood caries is the presence of any decayed deciduous tooth surface, cavitated or non-cavitated, missing due to caries or filled in a child who's younger than 6 years, that is 0 to 71 months, is considered as early childhood caries. Okay, then this is the nomenclature. There have been several terms which have been used by a number of researchers, okay, beginning from 1930s till date, and the most recent name which has been given to nursing bottle caries is early childhood caries. So earlier these names were put forward by a lot of researchers like Les Dents, Noire, date out all those things, nursing bottle caries, nursing caries, baby bottle tooth decay, milk bottle syndrome. Okay, but now the standard term which is used is early childhood caries. Okay, according to Davies, it's a complex disease which involves the maxillary primary incisors within 1 month after eruption, and it spreads rapidly involving the other primary teeth, and this is the reason that it is considered as a type of rampant caries. See, this is how it starts. You can see a pitting over here, okay, and here the cavitated surface starts as chalky white appearance and then it becomes cavitated. Okay, here you can see, so this is early childhood caries. The decay, it often appears as one or two small cavities on some surfaces of one or two teeth, and usually it starts from the upper front teeth, since these are the ones which are in contact with the milk or the formula while the infant is suckling. Okay, so now let's see what is the difference between rampant caries and nursing caries. Okay, rampant caries is acute widespread caries which spread very rapidly and involve almost all the teeth, while nursing caries are a specific form of rampant caries. This can be found at all the ages, while this is found only in infants and toddlers. Here it can involve primary and as well as permanent dentition, whereas nursing caries involves only primary dentition. In rampant caries, the mandibular incisors, they are also affected, whereas in nursing caries mostly the maxillary incisors and molars are affected. Mandibular incisors are spared. Etiology is multifactorial. Here this is mainly because of the bottle feeding habit, the pacifiers dipped in honey or other sweeteners, or at will breastfeeding. So it is related to nursing and the feeding practices. Therefore the terminology nursing caries. Okay, then treatment, pulp therapy. Here the treatment approach is basically more preventive. Okay, topical fluorides, maintenance of the teeth, and dental health education is required in both of these to prevent these diseases from occurring. Okay, now classification by Vinay. The classification includes three types. Type 1 is mild to moderate, type 2 is moderate to severe, and type 3 is severe ECC. Okay, so type 1, let's have a look. Mild to moderate, it is existence of small isolated lesions, okay, involving incisors and molars. The number of carious teeth increase as the cariogenic challenge persists in the oral cavity, and this is seen usually at the age of 2 to 5 years. Then comes the second type, okay, which is moderate to severe. In this, the labiolingual lesions affecting the maxillary incisors are seen. Mandibular incisors are usually not affected, and use of feeding bottle or at will breastfeeding or a combination of both with poor oral hygiene is the reason, and usually seen soon after the eruption of the teeth. Then there is a type 3 which is severe. In this, the caries, they affect the lower incisors as well, and the cause is cariogenic food, poor oral hygiene, and this is a rampant condition. So the recent definition has stated that severe ECC is in a child who is younger than 3 years of age. Any sign of smooth surface caries is indicative of severe ECC. Okay, from age 3 through 5, one or more cavitated, missing, or filled tooth surface in primary maxillary anterior teeth, or a decayed missing fill, that is DMFT score of more than equal to 4 in a child who's 3 years, more than equal to 5 in a child who's 4 years, or more than equal to 6 in a child who's 5 years constitutes severe ECC. Okay. So as the disease it gets worse, more teeth become affected, usually the back teeth, and the lower front teeth usually they are spared because they are covered by the tongue during suckling. Also there is salivary secretion which acts as a buffer. Then the etiological risk factors, the causative factors can be divided into primary and secondary. Primary are dental plaque, the mutans streptococci, infant feeding patterns, toothbrushing, salivary factors, sugars, oral clearance of carbohydrates, milk, bovine milk, human milk, fluorides, and secondary factors include tooth maturation defects, race and ethnicity, acidic fruit drinks, socioeconomic status, dental knowledge, stress, and other factors. Okay. Now this is the basic keys diagram of dental caries, in which he stated that it is the host, bacteria, and the substrate, all three need to be present to cause dental caries. This was the previous model, and then it is modified in which time is also included as well as saliva is also included. So here this states that host, substrate, and flora, microflora, that is microorganism, substrate, that is carbohydrates, and host, which is tooth surface. All three need to be present, and also the saliva plays an important role. So host factors or the tooth factors include age, also the appetite carbonate level, the fluoride content, genetics, microporosity, morphology of the teeth, nutrition, trace elements, the flora or the microbes, the fluoride and plaque, lactobacilli, streptococci, oral hygiene, transmissibility, virulence factors, all those things. Substrate include carbohydrates, the detergency of the food, and frequency of eating of food, oral clearance, how fast the food is getting cleared, and physical characteristics of the food, whether it is sticky or it is non-sticky. Okay, then saliva, the bicarbonate level, buffering capacity, composition, flow rate, and pH of the saliva. So all these factors, they play a role in causing ECC. So let's quickly have a look at the basic pathophysiology, what is occurring during caries. See, this process of demineralization and remineralization, it keeps occurring. Normally or naturally this process is present in the oral cavity. Demineralization, what happens is that when we consume carbohydrates or any kind of, especially sucrose, the sugar which is considered as arch criminal, the pH drop which takes place causes the rise in concentration of H plus ions, that is, it causes the pH to become more acidic, and thus the H plus ions lead to the leaching out of calcium and phosphate ions from the tooth, and this causes softening of the teeth or demineralization. The minerals are coming outside the tooth surface. Okay. Then remineralization is when the opposite of this takes place. During the alkaline environment, what happens is the H plus, to neutralize it, comes out of the tooth surface, and the calcium and phosphate is again transferred back to the tooth. So this is how remineralization takes place, and there is a balance which is maintained in healthy situation between these two processes, and this balance leads to no caries. But as soon as the balance is disturbed and more amount of demineralization takes place, then caries occur. Okay, this is the ecological model where we can see if the attacking agents are more, ECC is bound to happen, and if the host resistance is more, then there is no ECC. Okay, so these four factors, they must be present for the tooth decay to occur. Okay, a tooth which is not well protected by saliva is tend to be affected by decay. Also, acid producing bacteria or germs, that is Streptococcus mutans, lactobacilli, all these are responsible. Sugary or starchy foods, fermentable carbohydrates in the mouth. So all these factors play a very important role in causing dental caries. If there is repeated exposure to the bacteria, and then this demineralization process is bound to occur. So microbiology of dental caries, the cariogenic bacteria has to be acidophilic. That is, it secretes acid. Also, it lives in an acidic environment, and acidogenic, it produces acid. Lactic acid is the main acid which is being produced. There is early colonization of mutant streptococci. Okay, Streptococcus mutans, the ecological niche is on the tooth surface. It is found in the dental plaque and leads to development of microflora and acid production in the dental plaque. So mutant streptococci, the main bacteria which cause dental caries. Streptococcus mutans is the name of the microorganism. Mutant streptococci comprises of a group of streptococci which cause dental caries, which include Streptococcus mutans, Streptococcus subrinus, Streptococcus salivarius, all those. Okay, so the main bacteria which cause dental caries is this. It is responsible for the initiation and progression of early childhood caries. Okay, early childhood caries patients, they have more than one clonal types of Streptococcus mutans. And in rampant caries patients who are breastfed, they have 100 times more mutant streptococci. Okay. The virulence depends on these factors, that is production of glucosyl transferases, production of extracellular polysaccharide, acidogenicity, acidurity or acid tolerance, and production of dextronases. Okay. Then establishment, it can be transmitted vertically as well as horizontally. Vertical transmission takes place from the mother. It is seen that maternal salivary concentration of Streptococcus mutans affects the infection rate in infants. Okay, and it's not cultured from the oral cavity prior to eruption of teeth. Once the child is born, the oral cavity is sterile, but mutant streptococci, it increases with age or as the number of teeth increase. Okay, so streptococcus mutans usually colonize by 6 months of age, and mothers are considered as the main source of streptococcus mutans, mothers or the primary caregivers. Then lactobacilli is another important microorganism which leads to progression of dental caries. So before Streptococcus mutans was discovered, lactobacilli were considered the main bacteria causing caries. There is a correlation between the lactobacilli count and caries. They are found in relatively high proportions in cavitated lesions. The counts in saliva reflect total carbohydrate consumption, and children from whom both mutant streptococci and lactobacilli are isolated, usually they exhibit greatest caries exposure. Okay, so there's been a lot of research done on the microbiology of dental caries, and these are the most important microorganisms which have been discovered to be the causative agents. Then comes the concept of window of infectivity. What is window of infectivity? The newborns, like I told, are sterile at birth, their mouth is sterile at birth, and their normal flora is being acquired during birth or within a few days. And the time period during which this initial acquisition of mutant streptococci takes place on the primary and the permanent teeth is considered as the window of infectivity. So for both primary and permanent teeth, they provide a virgin ground for the microorganisms to attack on them. This provides mutant streptococci to colonize in the oral cavity before other bacteria can colonize, to prevent any kind of competition. Okay, now see, when does this window occur? So there is a first window of infectivity which occurs when the first tooth erupts in the oral cavity, that is 6 months to 5 years, the primary dentition stage. So the mean age which is considered is 26 or 27 months, and the range being 19 months to 31 months. So the 19th month to 31 month, this time period is considered as the first window of infectivity, during which the caries is the child is at more risk to develop caries, because there is an attack by the, there are high chances that the teeth will be colonized by mutant streptococci. And second window of infectivity is usually speculated at the age of 6 years when the first molars are erupting. Okay. So now how this transmission takes place, it can be vertical transmission, which is from the primary caregiver, that is mother usually, and maternal, like I told in one of the studies, it has been shown that maternal salivary concentration of Streptococcus mutans affects the infection rate in infants, and horizontal transmission can also take place, that is between the members of a group or family, play group, daycare, nurseries, classroom. Okay. Why mother is being considered as the main culprit is because there is most importantly the most intimate contact which is happening is with the mother. There is sharing of utensils, kissing. um, the mothers or the caregivers, they may infect the child while sharing any kind of food or utensils. Mothers have a habit of blowing air on the food while feeding the children, and kissing, etc. Okay, immunological factors transferred from mother to child in utero and through breastfeeding. Then spends most of the time with the child, more likely if the mother has decay, and early spread increases the decay risk. Then diet and substrate, physical form, consistency, and the frequency at which the starchy or the sugary diets are taken affects oral clearance of sugars, karyogenicity of the foods, and sucrose is considered as the arch criminal. It's an important question. Why it's considered arch criminal is because it causes dental caries, and then there is a loss in the arch perimeter because we are losing the tooth structure over there. Okay. Is milk cariogenic? This is a question on which a lot of research has been done, and there are studies which have shown, lot of studies which have shown that milk is not cariogenic. Okay, milk rinse and acidity has been studied in detail by researchers. Then it has been shown that cheese extracts, they protect enamel against acids, so cheese has an important protective effect on the teeth. And bovine milk, human milk has been compared, formula milk. So there's a lot of research which has been done on these, and we need not go into that much detail. But yes, milk alone does not cause caries. Only when milk is sweetened with sugars, then it causes caries. Plus, at will breastfeeding, that is, whenever the child demands, on demand breastfeeding, and all those kind of feeding patterns, frequent breastfeeding, these affect the development of dental caries. Okay, so the lactose concentration 4% in bovine milk, 7% in human milk. Breastfeeding associated with 5 to 10% of caries. Addition of sugar renders the milk cariogenic. Okay, this is one of the major factor why children who are bottle fed are prone to more dental caries, because bottle milk is dumped around the teeth. If you see, this is how the nipple from the bottle goes inside the mouth, and it lies here up to here. So the milk which is expressed is dumped around the teeth, whereas the milk while the child is breastfeeding is usually expressed into the throat. Okay, not around the teeth. So this is the reason why children who are breastfed compared to bottle feeding are at a less risk for developing caries. Formula milk, same thing, less cariogenic when compared with sucrose. Cariogenic potential of homemade weaning diet is less compared to commercially available foods. And acidic fruit drinks, they decrease oral pH, and therefore they are more cariogenic. Then the use of pacifiers and caries, it's also called as comforter or dummy. Okay, use of pacifier alone does not cause caries, but if there is a frequent and prolonged use of pacifiers which are dipped in honey or other sweetening agents, then that will have a detrimental effect on the teeth. Time is a very important factor. So when we say time, it is the frequency and the length of feeding. Okay, frequency, how frequently, the number of times the child is fed, and the length, that is the time duration. Bedtime bottle feeding, at will, nighttime nursing, or carry along bottle or no spill training cup, frequent snacking. All these are the factors which cause dental caries. Putting a child to bed with a bottle containing anything but water can be especially damaging to the teeth. Okay, during sleep, what happens is that the salivary flow, it decreases greatly. So any liquids which are there in the mouth, anything which is there, remain on the teeth for a longer period of time and is more likely to cause tooth decay. Then salivary factors also play important role. Saliva is the main host defense system which is there. It helps in clearance of food. It has a buffering capacity because of the buffers which are present in it. It mediates selective adhesion and colonization of bacteria on the tooth surface, and it also contains several antimicrobial systems like lysozyme, lactoferrin, peroxidase enzymes which aid in elimination of the bacteria. Okay. Then there are certain other additional risk factors like medications, medical conditions, and immunological response, malnutrition, hypoplasias, which affect development of caries. Then there is a role of socioeconomic factors, behavioral factors. Significant correlation exists between parents' dietary carbohydrate intake and the oral health of the child who is dependent on them. Risk factors contributing to higher caries prevalence in children of low socioeconomic background have been seen because of lack of knowledge or lack of oral hygiene maintenance. Okay, then parents' income and educational level also has to play an important role, and the effect of of family structure on dental caries has also been studied. Okay. Then comes the management part of it. How do we manage a child which comes to us with early childhood caries? We have to first of all identify all the causative factors. Okay, so for that we need a detailed history. Parental counseling needs to be done, and we have to treat the emergency first. Like if the child has come with with pain, then we have to make sure that we relieve the pain, and then thorough diet history has to be taken, and then if diet diary is required, that is to be given. We have to record plaque and gingival indices time and again. First visit, usually counsel the parents, oral prophylaxis, oral hygiene indices, then x-rays are to be taken. Second visit, analyze the diet chart which is given during the first, and then do diet counseling if required. Then repeat plaque and gingival indices. Perform Caries activity test. These tests help us in assessing the risk the risk of development of caries. Okay, third visit is permanent restorations, pulp therapies followed by crowns, extractions followed by space maintenance. So all the endodontic and prosthetic part or rehabilitation comes in the third visit. Okay, and this is a table which is summarizing disease management or clinical protocol which is to be followed. Okay, so initial visit or recall visit, if it is, you have to review the medical history completely and the dental history, perform a caries risk assessment test. Okay, then perform clinical examination and caries charting by tooth surface, and then take radiographs if it is indicated and possible. Assess the cooperation of child, because children who have ECC are very young, they are less than 5 years of age, so you have to assess the cooperation as well. Apply topical fluoride. Preventive aspect is the most important part of management of ECC. Okay, then inclusion criteria: at least one tooth decay, cavitation or demineralization, or a history of tooth decay has to be there for this. Effective engagement and communication has to happen. Explain the caries process, causes of ECC, define some self-management goals like diet, proper diet, oral hygiene maintenance, fluoride toothpaste, sodium fluoride, sans fluoride, and other remineralizing modalities. Okay. During the management, during the follow-up visit, perform a caries risk assessment again. Okay, so if the child was previously in a high risk, now the child should fall into moderate or low risk. Okay, perform clinical examination and caries charting, take radiographs if it is indicated possible, redefine and re-emphasize the self-management goals, assess the cooperation, apply topical fluoride, and then last is the restorative surgical treatment. Restorative treatment as indicated or desired, and the intermediate or interim therapeutic restoration, and sealants. Then if it is rampant, then GA or operatory room or sedation is indicated. Okay, in children who are not cooperative or pre-cooperative age. So for children at high risk, this is the follow-up, how we decide the next visit. Okay, next disease management visit. So for children who are in high risk category, they should be followed up every 1 to 3 months. For children who are at medium risk, 3 to 6 months, and for children who are at low risk, 6 to 12 months. Okay. This is the ECC prevention protocol. So home care, professional and community. Home care, the dietary habits have to be improved. Fluoride dentrifiers should be used, supplements should be used, oral hygiene maintenance. Okay. Then professional early detection, diet counseling, fluoride, sealants, then community education, water fluoridation, community and personal development, and control of transmission of carcinogenic bacteria. That is the whole idea of it. Okay, so ECC prevention is the most important aspect in management. Then professional and home-based preventive approaches. If there are no signs of ECC or very low risk status, then we just need fluoridated dentrifiers and review the dietary chart, and oral hygiene indices can be taken to review oral hygiene maintenance. And the signs, if there are signs of ECC or high risk status, then fluoride varnish has to be applied, sealants have to be applied, chlorhexidine varnish, xylitol pacifiers can be given, fluoridated supplements and dentrifiers should be used, and dietary counseling has to be done. Okay, so this is all in brief about ECC, and early childhood caries. It's a chronic infectious disease which affects young children and constitutes a serious public health problem. It has a debilitating effect on development, speech, general health, and self-esteem of young children. So the critical step which is needed is to accomplish prevention of ECC, is to expand our network to include other health professionals, community leaders, national organizations serving children. Okay, let's quickly discuss few questions. So one of the questions which is asked is arch criminal and caries is, so the options are sucrose, complex carbohydrates, xylitol, glucose. So the answer is sucrose because this is the one which causes caries, and others in xylitol in fact has a preventive effect. Then question 2, dental caries in children are highest at the age group. Options 2 to 3 years, B 4 to 5 years, C 7 to 8 years, and D 8 to 10 years. So the best possible answer over here is 4 to 5 years because that is the second window of infectivity if you remember. Okay, so during the age when the first permanent molars are about to erupt. And question 3, first dental visit of a child should preferably at the age of. So here are the options: below 2 years, 2 to 3 years, 3 to 4 years, or 4 to 5 years. So see, ideally the answer should be below 1 year, because the first dental visit should occur when as soon as the first tooth erupts or by 12 months of age. But here the closest possible answer is below 2 years. So this is the right answer. Then another question is that nursing bottle caries may be attributed to A. Human milk, B. Non-human milk, C. Non-human milk with additives, or D. Feeding methods and susceptibility. So nursing bottle caries is attributed to, actually, if additives are sugars, milk which is sweetened, then that nursing bottle caries is definitely attributed to that. But the best possible answer over here is feeding methods and susceptibility, because that is the risk factor. Here what is written is additives, which we don't know what additives they're talking about. So the best possible answer is feeding methods and susceptibility. Then in diet counseling to reduce caries, sugar is restricted to meal times, or sugar is restricted to one time a day, or it is restricted to only liquid sugars, or it is restricted to fibrous foods. So in diet counseling, yes, sugar intake is restricted only to meal times, because we cannot ask the child to completely stop having sugars. Okay, if the child loves to eat chocolates, we can tell the parents that you have to, give it during the meal time. Parents should begin cleaning a child's mouth A. By the time the first tooth erupts, B. When all the deciduous teeth erupt, C. When all the anterior teeth have erupted, or D. When incisors and molars have erupted. So the answer here is by the time the first tooth erupts. Okay, but they've asked cleaning the child's mouth, not the child's teeth. So if the option would have been even before the eruption of any primary tooth, that can also be the answer, because we have to clean the gum pads also. Wiping of the gum pads is also recommended. Then another question is CAT or CAT in pediatric dentistry refers to. So it refers to Caries Risk Assessment Tool. Okay, out of all these options, Caries Risk Assessment Tool is a tool which was provided by the American Academy of Pediatric Dentistry to assess the risk of caries in infants and children and adolescents based on a set of clinical, environmental, and general health factors. Okay, so it assesses whether the child has a mild risk for caries development or moderate or severe risk. Okay, and that helps us in deciding the follow-up visits for the child. Okay, so this was in brief about early childhood caries. If you have any kind of doubts, you can get back to me. Thank you so much for listening, and all the very best.